Kia ora koutou, everyone. I'm very pleased to be introducing this VHIN webinar, and it's a fascinating topic, respiratory illness insights from Flutracking, participatory survey data source, and hopefully many of you are already participating in it and contributing to this work. And we're really delighted to have Dr. Emily Harvey here, and as you will have seen from the information that went around, she's an experienced mathematical modeler. She's a researcher at ME Research and a principal investigator with Te Pūnaha Matatini, a Centre for Research Excellence. And she was also very active during the pandemic, and she co-led the network and individual-based modeling team and provided really important insights into understanding the pandemic and how to respond to it. So over to Emily.
Thanks, Michael. Today I'm going to be talking about a subset of the work that I did as part of the COVID modelling Aotearoa team. And so I'm going to start with the motivation of why we even started looking at this Flutracking data and some of the things we used it for. And then I'll shift into talking about other insights we can get from this sort of data and how I see it fits in respiratory illness surveillance in general, both for pandemics and pandemic preparedness, but also for our regular respiratory illnesses that we have circulating. As Michael said, I was involved in the COVID modelling Aotearoa team back in 2020, and the key questions, some of the many key questions we had around there when we had the elimination strategy was how soon would we detect a new community outbreak of COVID-19? And once we've detected it, what do we need to do to eliminate it? Can we eliminate it? What do we have to do to be able to eliminate it again? And so with the team, we were doing a large amount of these mathematical models of disease spread, including these individual and network contagion models. And so we were coming up with model outputs that look a bit like this. So on the x-axis, you've got how long after a new introduction, so that's an MIQ break. How soon, once this disease got into the community, would we detect it? How many days? And at that point, how big would the outbreak be? So there's a lot of stochasticity in this, hugely variable. And in terms of that second question, could we eliminate it? We could then model the impact of a lot of different interventions. And so this is just an example plot of, depending on how big the outbreak was, would we be able to eliminate it with just alert level 3 rather than going to alert level 4? And kind of the general idea was the smaller the outbreak at the point you detect it, the better. And the sooner you react, that go hard, go early response was very much borne out by the modeling. But for all of this, a really important bit of information that we needed for the modeling and that was needed in the community was what proportion of these people who have symptoms of that are consistent with COVID-19, how many of them are actually going and seeking one of these PCR tests? And that one thing, which is a behavioral element, was something we did not know. So obviously all that other modeling, we needed to have a lot of information about disease characteristics, generation intervals, asymptomatic proportion, test sensitivity, a lot of information about that. That's all very much, I guess, disease specific or test specific. But this behavioral element, where what proportion of people actually go seek a test, we didn't know it, and it was a big lever we could actually change. And so started to dive into that in 2020. And so luckily, with these PCR tests, they're all being done through the central government testing services. And so we actually knew, the government, the modelers, had information on how many of these PCR tests were being done each week. So all we need to know is, well, how many people that week had new onset of some symptoms that could be COVID? Once we know that, we've got number of tests, we've got proportion of people with symptoms, we just divide one by the other. That gives us our test proportion. Perfect, so easy. Great, let's go find out how many people had new onset of respiratory illness symptoms. Okay, so I'm going to chuck up here this surveillance pyramid that a bunch of the people in the audience or anyone around public health will have seen a variant of before. What we need to know is this bit. We need to know who had new onset of symptoms, and that can be just sore throat, bit of a runny nose. It could be cough and fever, but there's a whole range of levels of symptoms that you can get, especially early on with COVID-19. And what we found was that pretty much almost all of Aotearoa's respiratory disease surveillance was focused on the more serious influenza-like illness. So that's often defined as fever and cough. And it's also only really able to have eyes on or know what's going on with people who seek healthcare. So you've got to go see a GP, you've got to turn up at a hospital, you've got to call Healthline, things like that. So that was a gap. And what we found as a solution for this, and we're back and forth talking to people at Ministry of Health and in government, was that actually this Flutracking survey data was going to be so valuable. And luckily, I've got a big arrow there. On that plot on the left, you've got how many people were responding to Flutracking every year. And in response to the COVID-19 pandemic, Ashley Bloomfield and Jacinda Ardern actually mentioned it in some press stand-ups, and there had been a massive uptick in responses. So in that period in 2020 and even in 2021, we actually had quite a lot of responses that we could look at. And for those of you who don't know, here's an example of what the survey looks like. So this is right now, it was a bit different then, but the key thing is it asks about a number of symptoms that could be consistent with COVID-19 or influenza, respiratory illness in general. And then it also asks whether you had a test, so a PCR or now a rapid antigen test for COVID-19, and about vaccination. Also, if you say you've got any of those symptoms, it also asks if you contacted a health professional, and if so, which. So it'll ask you about GP, and it also asks if you are absent from work or normal duties because of your illness. So it's a really rich data source that can be used here. And right off the bat, just want to say before I get into it that all of this has been shared in a MethodsX publication about the method, and there's open source R code with some dummy demonstration data. And I've just put the link there, but you should be able to find it if you Google it. And a key thing that we did was that, like I said, COVID-19 like symptoms that we want people to be going to get a test for aren't only the more serious influenza like fever and cough. We actually at that point wanted to detect an outbreak early, so we wanted anyone who had any one or more COVID-like symptoms. And so you'll see in the next few slides, CLI1 plus just stands for COVID-like illness, one symptom or more, and CLI2 plus, you might be able to work out, is COVID-like illness, two or more symptoms. And so that was one reason to do it. The other thing was because of that alert level 4 in 2020, New Zealand and the border closures, New Zealand had managed to actually eliminate influenza and RSV and probably a number of other nasties temporarily from our country. And so the actual levels of this influenza-like illness with fever and cough were very low and weren't giving us a useful signal. All right, so just going to show you a bit about the progression of how it went. So in August 2020, which was sort of about the week that we first got this data and started trying to use it, we wanted to look at the proportion of people, incidents, so new onset of symptoms in the data set who got tested, and we looked at before I think it was August 11th, 20th, whenever it was the week before that Auckland outbreak had occurred, and we found that about 9% of people who had symptoms were going and seeking this PCR test. Whereas the week after, once there was a known outbreak, that had more than doubled to more like 19% of people with these symptoms were going to seek a test. So that was a sign, partly that we were picking up a real signal, but also that it was a shift in the right direction. The other thing here is we looked at how long it took after someone got sick before they went and got that test. And what we found is that before the outbreak, that 9% of people who went and got a test, well, they didn't necessarily get it right away. About a third of them, it was more than a week or two after the symptoms had first turned up. Whereas once we'd had that outbreak, during that outbreak, people mostly got this test as soon as they could. So that was a great piece of information, and estimates like that about the proportion getting a test and how quickly they got a test directly fed into a lot of the modelling that we were doing in the advice to government. By December 2020, I don't know about you, but those tables weren't maybe super friendly to share. We started looking in a bit more detail at this data and breaking it down with more plots, more intelligible, kind of interpretable insights. And so here is a plot of, through time, the proportion of people in this Flutracking data set who got a PCR test when they had new onset of some respiratory illness symptoms. And so you can see quite clearly, hopefully, that it was mid-August or early August sometime when that Auckland outbreak happened, and suddenly, a lot more people were going to get a test. This is against a background of actually the level of symptoms were going down because we were all in lockdown. But yeah, more people were getting a test. And as we saw repeatedly over the last few years, the testing rates are always lower in younger kids, and there's a large number of very sensible reasons for that. But it was good to see that showed up in our data set, and good to see that there was good high testing rates in all those adult populations. The next thing we looked at is that we became quite aware that Flutracking participants are not representative of the general public. We sort of already knew that, but a really nice thing that we knew with the testing that was going on is we actually knew how many tests had been done, how many PCR tests in the whole country. And then we also knew how many people in that Flutracking set of respondents had had a PCR test done. And there were very different proportions of the Flutracking population who'd had a test done versus the general population. And this bias is due to a number of reasons, some of which are the sort of people who sign up to and respond to Flutracking are more likely to be engaged and invested in the COVID-19 response, and so are also more likely to go out and seek a test. But there are also other biases around the proportion of people in the Flutracking response category who are in the healthcare system and would be more likely to be cautious and get a test. So what we wanted to do in order to get an estimate of the general population testing rate from the Flutracking data was use that information about number of tests to estimate the bias in that testing rate. So what we can see is that started off that the Flutracking population were at twice as likely to go get a test. Then in the key main outbreak, it dropped down that actually everyone was really likely to get a test. And then it crept back up through time. So by December 2020, sorry, I don't have the year on this plot. By December 2020, Flutracking respondents were 4 times more likely to go and seek a test if they had symptoms than we would suspect in the general population. So that's one of the things we used it for. Another thing got even more kind of refined in our analysis with this data to do with testing by August 2021, which you might remember was the second Auckland outbreak, the Delta outbreak. What we found was that the couldn't find a plot of this, sorry. There were a huge number of tests in the first couple of weeks after that outbreak. And then the number of tests being done really dropped off a cliff. There were not a lot of tests going on. And there was a lot of concern in the media and in government that maybe people had gotten sick of the COVID response and weren't going to get a test. But the important thing to remember is that we'd only told people to go get a test if they were contacts of a case or if they had symptoms. And one thing that alert levels are really good for, alert level 3 and 4, is stopping the spread of respiratory illnesses, which meant that the level of respiratory illness in the community dropped off a cliff when we went into those lockdowns. So of course, you're going to expect to see a big decrease in the number of tests done because you've got a big decrease in the amount of people who are actually sick. So we looked at that. This plot here shows that drop off depending on whether you care about just one symptom or two. And you can see drops right off and then starts to creep back up once alert levels start being decreased. And we ended up doing some much more kind of involved modeling where we estimated from the new people getting sick and how many people were getting tested, what was the total population in the community who had symptoms, that new onset of symptoms that week, and then how many of them were untested. So the dashed line is our estimate of the untested symptomatic population. And we split that by different parts of different regions and by different age groups, because we had all that information for both symptom incidence from Flutracking and in the testing data. And so what we could see is that within the first week or two of that lockdown, we estimate that everyone with symptoms pretty much was going out to get a test. And it was only really once we got to later on in the lockdown that probably there were some who were untested, maybe, but again, only if you were considering the milder symptom end of things. So much more complicated modeling as we went on, but always that Flutracking data letting us know what proportion of people are actually getting sick every week with that new onset of respiratory symptoms. All right, so that's how some ways that it fed into the COVID response. And one thing I wanted to say was that as we started trying to use this data set, and the key thing we wanted to use it for was estimating that new onset of COVID-like symptoms, we realized that there were a lot of biases in the data set that we needed to be careful about and adjust for in our analysis in order to get the best possible estimate of that incidence rate. That incidence rate is the core thing we were after. And so the first thing to note was that the age of respondents in that Flutracking survey didn't match the ages in the community exactly. It was actually not that bad in early 2020. It's much worse now, but it wasn't representative of the population, and that wouldn't matter so much if everyone in the population had the same sort of incidence rate of getting sick. But what we could see from the data was that different age groups have really different rates that they get sick, they get these respiratory illnesses. Anyone with kids or who's interacts with kids will know kids get a lot more respiratory illnesses. Especially that ILI, fever and cough level. Under fives have just a much higher rate of that level of illness. And you see, one other thing we see is that we also see a bump in the kind of, I guess what I'd call the parent age group, which may be connected, who knows. So what that meant was that we couldn't just use the raw data for, okay, how many people in Flutracking had new onset of symptoms this week? Okay, that's the proportion for the population. We had to reweight it by those age proportions, something often referred to as age standardization. So that was the key first thing we did that made the biggest difference. The other thing we did is that actually that the rate that people were interested in was often not those high levels of illness in the under fives. And so we often produced two different estimates, one that excluded those under fives, the rates in the under fives, because that's really capturing a different sort of dynamic. The other key adjustment we made was that it turns out people are much more likely to respond to this sort of flu tracking survey when they are sick. So when they're not sick, they think, oh, I've got nothing to say, I won't respond, which is unfortunate because absence of illness is also a very important thing that we want an estimate of. And so that meant that what we wanted to do was define, we used a moving window to say we're only going to use your information if you've consistently responded for 3 of the last 4 weeks. So we looked at this window and we said, have you been responding for the last 3 weeks? Yes, okay, we'll use your data. If not, no, we're not going to use your data this week. And so that meant that people could be consistent for a while and then not, and that gave us the biggest data set whilst removing this bias. And there's some more information in the paper, but like I said, we had a 4-week window and we allowed 1 missing week. And the reason we did that is we looked at how much did the number of weeks that the window was, how much did that affect our incidence rate estimate? So that's the x-axis. And then what fraction of our responses did we lose? How many bits of information did we have to throw away? Obviously, the bigger window we have, the more we're going to throw away. And so we kind of used our judgment to pick the level where we had the clearest impact, most accurate level where we'd removed that bias, but we weren't throwing away too many symptoms. And that was that 4 weeks and allow 1 missing week. And then we also see here, okay, what impact does it make? So like I said, people are more likely to respond when they're sick, which is the top graph. So what that means is that when you exclude those, oh, I'm suddenly sick, I'm going to respond, responses, your true estimate of the true incidence rate decreases by, it's variable, but by 5 to 10%. So if you don't do that adjustment, you're going to be overestimating the incidence rate. Next graph down is, well, what happened when we applied that age standardization? So like I said, younger children in particular have much higher incidence rates. And what we found was that they were also the least represented in the survey. And so that meant that when you did this age weighting, your estimate of the weekly incidence for the more mild levels of COVID-like illness increased maybe around 10 or 15%, and it increased even more for the ILI-like illnesses, the fever and cough, which in the last slide I was showing were much, much higher in under fives. And one thing to note, this ramps up with time throughout 2020 because what we saw was that age representation, in particular, the number of under 65s, in fact, was getting worse and worse through time. And so how do those effects combine? Varies every week. And it's worth doing that to get the best possible estimate of what's going on in the community. So I've mentioned this is just a giant, terrible table. But in terms of the representativeness of the flu tracking respondents, I've already mentioned the age. A few other things to note: Wellington this is 2020, but I think still is incredibly overrepresented in flu tracking responses, which does mean that when you look regionally, you actually get a better estimate for Wellington than for a number of other regions. And also that the majority of the respondents select Pākehā or New Zealand European as their ethnicity. So that's an issue for the survey. The other thing is that for all the other ethnicities, because of the biases to do with the region, but also if you look at working in healthcare, things like that, we don't believe that the people in Flutracking are representative of their own ethnicity necessarily for actually all of the groups. So we never actually produced estimates of incidents for different ethnicities using this. We would need the sample to be, the survey to be much more representative before that would be a safe thing to do. The other thing just to note, and this is a bit of a exploratory diversion for people who are interested, is that in the survey, there were slightly more women than men answering, which is so 55 to 45 is actually less than you'd see as a gender bias in most surveys. If you look at voluntary surveys, there is a strong female bias often. But what we saw was that incidence in this data set was higher in women consistently. And we wanted to think about why that was. We looked into, is it just that there's an age difference in this survey? Women are younger, and like we'd said, incidence rates are higher in younger people. No, it's not that. Then we looked at, is it just that women are in households with kids more than the men answering the survey? And because the survey's answered as a household, we could delve into that, and we saw no. Even when we look at just women and men who are in households with kids, we still see the same effect. And when it got down to it, the key driver we found for this seemed to be that there's two options with Flutracking. One is that you are responding for yourself, and the other is that you are responding for yourself and your household. And so if you're responding for other people as well, we found that those people who are being responded for had lower reported incidence rates, and different symptoms were reported when we looked at the profile. So in particular, having a sore throat was one of the highest reported symptoms in self-reporting, but was third or fourth down the list when someone was being reported for. And that's because having a sore throat is not the sort of symptom that is easy to see in someone else, especially in adults. Unless someone complains about it, you're not going to know. Whereas coughing and runny nose, you are going to know about that. So that was a bit of a diversion. Again, this is a really rich data set. There's all sorts of things that could be done. We were really driven by estimating that overall incidence for the COVID response. But yeah, it's a really rich, interesting data set. And where did that go? So as part of that work, and kind of as a thank you to all the people who were taking the time to diligently respond to the survey each week, we did a piece with Susie Wiles, just kind of saying how it's actually been really helpful and thanking people. It was sort of a call out to sign up as well, but the key thing was wanting to really thank people and let them know that their responses were valuable and were valued. And we also, as part of our analysis, we made this incidence estimate because, like we said, there's a lot of biases that we'd found. And so we believed that this was a more accurate estimate of the incidence rate. It also looked at these other symptom definitions, milder symptom definitions, and it was able to be split by health regions or health districts in a way that the public report couldn't delve down into. So this was a way that people could get information about, is respiratory disease in the community looking like it's on the rise in my area or in my age group, kind of what's going on. So that's publicly available. That's still up now. What else? Yeah, so that's sort of where we've stopped looking at it. What I wanted to move on to now is where I think this sort of flu tracking participatory survey data could, and I think should, fit into respiratory disease surveillance. So right off the bat, I want to say that Aotearoa New Zealand has some just incredible work on respiratory illness surveillance. So there's ESR has the acute respiratory illness dashboard that you can look up almost real time with last week's data on, in particular, that severe respiratory illness, so hospital level acute illness, and a lot of detail on the genomic analysis, what viruses are being detected in the labs, things like that. There's also the Shivers or Well Kiwis program, which is incredibly rich information about, for that cohort, what's going on throughout the year with respiratory illnesses. And now the COVID wastewater surveillance program that ESR runs. So there's a lot going on, but there are, I think, some gaps, and some of those, I think, are where flu tracking can fit in, or something like flu tracking. So then going into the big picture, so there's the WHO, World Health Organization, has this framework called Crafting the Mosaic. I always kind of had thought of flu tracking data as one piece of the puzzle when I talked about it, but I guess one piece of a mosaic works as well. And so just going through these three domains which the World Health Organization has identified. So the first is the detection and assessment of an emerging or re-emerging respiratory virus. Could participatory surveys like flu tracking feed into that? I say, yep, absolutely. In particular, like I was saying just before, a lot of the other data sets rely on being quite sick, so ending up in hospital. And that is often the very young kids and the elderly. And it also relies on healthcare seeking behavior, so going to a GP. And there's a large proportion of the population who are much less likely to go to a GP if they're sick, even be able to go to a GP if they're sick. And that age group is, and parts of the community are often the people who we would expect a new or re-emerging virus to spread the fastest in first. And so by not having the tracking in those populations, so it's your university age, really high contacts, less likely to get really sick when they get a respiratory virus, less likely to go to hospital. If you don't have a way of knowing what's going on in those communities, you're missing out on potentially weeks of an early warning signal that something new is coming in. And flu tracking has the opportunity, if it has good enrollment in those cohorts, to actually be that early warning signal. Next up, what have we got? Monitoring epidemiological characteristics. So like I said, it's a really rich data set about what symptoms people had when they got sick. And if that is combined with a positive test result that they've reported, which would mostly only be for COVID, might be for influenza, you can directly say, okay, people who tested positive for COVID, what symptoms did they have? Has it changed with age groups? Has it changed through time? That's really one option. The other thing is, once you combine this information with the other information that ESR are getting through the virus, and the labs, through what viruses are out there, you can see when the waves of different viruses are coming through, and then you can look at that compared with the symptoms that are being reported and get information. There will be other ways too. These are just sort of the key things I thought of preparing this talk. And then this final one about use of interventions, I would say that flu tracking data set can tell us a lot about partly what people's behaviors are in terms of, are they going to a GP or not when they get sick? And so how might our GP reporting rates be an under or overestimate of what's going on? But they also indirectly tell us a lot about other behaviors. So one thing that we use this data set for a lot is that the new weekly incidence, so new onset of symptoms, is a proxy of your contact rates for the most part. So what we see is that when people's contact rates decrease, the incidence rates of viruses decreases. And we see this consistently in the data, especially for the 2 or more COVID-like symptoms, which are catching your rhinoviruses and a bunch of viruses that are kind of always about. And so this is a plot of in 2020, what did we have? Well, we had our main lockdown. That's the grey period at the beginning. And so incidence of all sorts of symptoms were very low. And then, okay, we went back to business as usual, and okay, we'd got rid of COVID and influenza was gone and RSV, but there's other bugs around. So you see this upshoot in the rates of illness, drops off again, that's school holidays, goes back up, that's going back to school. And then in green, that's the COVID outbreak. And you can see that with those alert levels being introduced and people being cautious, you've got the respiratory illness rates dropping right down. And you can see clearly that they drop right down way more in Auckland that had the stricter alert level in place, whereas the rest of New Zealand didn't have the alert levels in place, but were being cautious. And so they still had decreased rates than you would have expected without that lockdown. So you can use this to both get an estimate of what impact your intervention had to inform your use of interventions, but you can also use it just in general to get a feel for, well, what sort of contact rates and mixing are going on that are spreading your day-to-day usual viruses here. What else? So there's a preprint out, EELS et al. So this includes James McCaw and Freya Shearer from Australia. They've done some really great work during the pandemic and acute response and still ongoing, thinking about what are the surveillance systems that you need in place, what sort of data do you need to be collecting. And so I recommend looking at this paper. There's a plot here, and I really like that they talk about how you need these enhanced surveillance bits of information for some parts of the information, well, some parts of your response, but then you also need all of these different levels of the pyramid, and you need to be looking at different pathogens. Where does Flutracking type surveillance fit in here? Well, I think it fits in a lot of these levels. So it fits in what's happening in the community, how many people are getting symptoms, how many people are seeking care, how many people are taking tests, that's all in there. But it's also, like I said, indirectly getting at, well, how many contacts are people having? Yeah, that sort of thing. One example of that is that you can, and this is from just last year, 2023, you can look at what proportion of Flutracking respondents who had new onset of symptoms did a rapid antigen test that same week. So this is just some exploratory data analysis, but what you can see is that in early 2022, where this plot starts and rats were new, and so early 2022, get my years right, and the main wave of BA1 and 2, that Omicron wave was coming through, the testing rate, especially if people had fever and cough, was very high, so up near 100% of those people. And this is not age weighted, so it includes a bunch of kids and things, and rats weren't super easy to get straight away. So very high testing rate. But what's really interesting is that that rate has stayed really high. There's the big caveat that, okay, it's your Flutracking respondents, they're more engaged, they're going out and filling in the survey every week. But it is still really high, and you can also see really clear shifts through time, which are in response to when there have been waves of more infections and when there's more awareness. So you can see one that happens near the end of 2022. There's a new variant wave that went through there, and you can see, oh, okay, yes, there's more COVID around, I'm going to go get a test. So you can kind of see a bit of that interaction in this data. In order to say anything quantitative or strong about it, you'd need to do much more detailed analysis. This is just exploratory, but just giving you an idea of some of the sort of interesting information that this sort of survey could give you information about. And also, like I said, can use this sort of survey to get insights into healthcare seeking behaviour, who is choosing to, who is able to, and for what symptoms. What else? So one thing that I care about a lot is that our existing surveillance systems that really focus on that severe end of that pyramid that I showed before. And that's really important. We definitely need to be doing that. And at that end, we can see, so this is just a screenshot from the current week's ESR dashboard. You can see that there are really major inequities. And if you look at some of their influenza reports and respiratory illness reports, there's a number of persistent inequities in who is ending up in hospital with these diseases. Unfortunately, what we don't know a lot about is, what about all those respiratory illnesses that don't put you in hospital or that you don't end up going to a GP for? Don't those matter as well? I think they do. And there's all sorts of things you might want to quantify for that, and that's things like time off work, so loss of income, maybe even loss of job if you keep getting sick and having to take time off. There's time off school for kids. There's a lot of different impacts on personal and community health and well-being when there are high rates of these respiratory illnesses going on. And so I think it's really important to be able to estimate, where is the burden of this disease lying? Is it evenly spread and it's just at the severe end is got these inequities because of other health inequities? Or are there actually more infections in some communities than others? And what could we do about that? Because in general, it's often hard to justify an investment in reducing a burden if we haven't been able to measure what that burden is. And there's a lot of interventions that we know could reduce the burden of these acute respiratory illnesses. We know a lot, especially from the COVID response, about what works to reduce spread of these things. We know that improved indoor air quality makes such a big difference. We know that having better housing quality, so not damp, having better ventilation in houses, not having crowded houses makes a big difference to that household spread. We know that vaccinations help, especially obviously for the only for the viruses that we have vaccinations for, but vaccinations help. And also workforces that have better sick leave provisions. That helps reduce the burden. There's the individual level where you don't have to lose income if you're sick, but it's also that you are not spreading disease so much in your workplace if you're able to stay home. And just as a bit of a note, I think I mentioned before, you can often really clearly in this data, Flutracking data, see when school holidays are. So it's when those contact rates change. And I think I also said before, we can also see in the data from the different periods in the COVID response that even in the alert level 1 and 2 phases, when people were being more cautious, there was less spread of respiratory illness. So we know a lot of things that can really work for reducing that. All right, so where are we at now? Getting to the end of this talk. So we've still got our public dashboard up with the Flutracking data on it for people to go and investigate and play with. A key thing to note is this data is actually only up until December 2023, so that's when the data feed ended. So now, if you want current data, you can only get that from the official Flutracking reports. How different are they? Well, so for the Australian data, they've implemented age standardization, but not the consistent respondents sort of adjustment. So it'll be closer to the sort of thing we'd measure, but not quite. And the New Zealand Flutracking team have so far implemented the consistent respondents adjustment, but haven't yet implemented the age standardization. And just as a quick worked example, you can go get from their report what percentage of responses last week in each age group, and we're down to 0.85 of responses are in the under fives, and you can compare that to the total population of around 6%, and you can start to see these differences. A really big one is that 41% of responses now are in people 65 and older, compared to the percentage in the population, sort of around that 17%. So that is unfortunately meaning that the analysis in the existing reports is really not as useful as it could be. And as an example, last week it reported 1.8% incidence, but if you did a rough age standardization with this data, the closer estimate we believe would be more like 2.4%. So that does make a big difference. And it's just this drop in participation and representativeness has been going on since the big enrollment surge in April 2020. And yeah, it's getting to the point where there's a lot fewer responses and they're much less representative, and that is meaning that it is less and less useful, unfortunately. All right, so how do we make it useful and used? I think it's really important that if this is a data set that the research community and the surveillance and response community want to get value from, really need to increase participation in anyone under 65 and also not in Wellington. So various things like that. ESR have a bit of a sign up drive going on at the moment. So until the end of June 2024, anyone over 12 who signs up to Flutracking for them and their family can win a Prezi card. And they also have asked all the current Flutracking respondees to forward the invite on to friends or colleagues to sign up. So there's that. One thing just at the end, hopefully I've kind of conveyed that I think this sort of data set's really valuable, but I do have some real concerns. Partly it's been 1.5 years of ESR being in charge of this data set, and there's still no data sharing process in place for researchers to actually access and use this data. So yeah, like I said, representativeness and response numbers are a real problem. And the other thing is I feel that there's a real social license risk associated with asking people to take the time to fill in a survey like this and then not using it, sort of not valuing people's time. And that seems like a really big risk. The other thing I'd note is that there's often incredibly valid reasons for people to not want to give this sort of information over to, the state. But I think there's a large value in these sort of surveys, and it's definitely the sort of thing where I'd like to see a bit more thought about whether there's community-led and community-run surveys of this type, or this sort of data collection and analysis to inform what's going on in my community, what should we be doing, how can we respond, what are there interventions we're making that are making a difference.
Well, thanks, Emily, for a really outstanding presentation. And there's so many questions I think people have mentioned in the chat, and also that I have and probably others have. I think there's a very good question from Li Feng starting off about where do we go to from here?
I think it's just about certainly, with the change, so many things, including, our health system, having just Health New Zealand as one entity, and also with, the adoption of the amendments to the IHR, and how can we actually, just in case of future pandemic, how can the whole system work together, to come out, to have timely access to everything that, that we should know, like, data and digital platform currently being developed by HNZ, and also the health analytics work by Delvin Armstrong's team within SNI, and they could provide like not only hospital data but also some potential other data sources. So how can we actually just make better use for all these different data sources for better information and possibly decision-making process. Thank you.
I mean, I'm not across, I'm within a private company and have just worked with data as part of the COVID response and COVID modelling Aotearoa. But I think ESR already with their dashboard. It's quite good having all that information in one place. There's also a lot of information that potentially doesn't need to be or shouldn't be public, and having ways to link that up for you folks in the health system is really valuable. I think the main thing that I kind of the point I want to make is to not forget about the illness that isn't interacting with the healthcare system, and maybe it isn't something that is a certain person's remit, but I'd like it to be someone's remit to care about that. And I think this sort of participatory survey data can be really valuable to feed into that. And the other thing is, I think that for the stuff that's already going on, I think it needs to be valued and it needs to be resourced so that it can actually become useful and used, because you have a very real risk of doing something halfway and then it not being useful and it taking quite a lot of time and money to not actually get the results. So I think actually having a clear strategy, working out what is this data being collected for, let's make sure it's used for it.
Thanks. And I would like to ask just a related question, and this is really about, I think, two things you touched on. One is about who owns the system and guides its development. And obviously that involves the data being used actively, as I think you've really pointed out very well. So if you could perhaps comment on that, because of course Flutracking is partly run from Australia, isn't it? It's an Australasian exercise. And then it's got some connections with our health agencies here, but they seem a bit imperfect. How do you think, and this is probably a good test case of how do we encourage, innovation, but at the same time integration of systems?
I didn't give that background, and there's a lot more detail on the Flutracking website for people who are interested, but it was set up originally by Hunter New England Health over in Australia and some other universities that I'm going to forget. And it's now, I think, 5 countries that it's run, this Flutracking survey is run in. And so I think the actual survey, a lot of that, the mechanics of it sits with Hunter New England, but there's within each country there's a group, and here you can see Giles Graham from ESR who actually deals with the administration of it, dealing with the emails coming in, working out any problems, adjusting what the questions are, that sort of thing. So within each country there's someone or some agency that's in charge of that, and then also is in charge of who can access that data and what analysis happens with it. One thing I'd say is there's definitely been increasing investment in this data over in Australia. They've got a whole team, and I every so often see job ads for whole positions just to analyze this data and do get value from it. So I think, yeah, some other countries using the data a bit more. The other thing is, this is not an exclusive to New Zealand and Australia thing. There's influenza net in Europe, and the American one, it's like Flu Near You or something. Yeah, so there's these sort of participatory surveillance systems worldwide, and everyone has kind of found that they are very useful. So yeah, I think it's just about working out where they fit now that COVID's not in that acute response phase anymore.
Yeah, and I think we're just about at time. Just a huge thanks, Emily, and I think your contribution during the COVID response was outstanding, and your group really did give New Zealand very, world-class insights from modelling, and I think you've really demonstrated that today as well. Just the application of a really high-level thinking to an established surveillance system. There should be a lot more of that, looking at the biases that we often don't take account of in these key data gathering systems. So I think we're very fortunate to have your insights throughout the pandemic and hopefully continuing long into the future. So I just want to thank you on behalf of everyone who's had the benefit of joining in today.